Hello, everyone, and welcome to the Great Plains Quinn Friday Focus for Health. This Friday Focus for Health is hosted by us, the Great Plains Quality Innovation Network. We are the quality improvement organization for North Dakota and South Dakota. My name is Tammy Wagner. I am a registered nurse and quality improvement advisor for the Great Plains Quinn. And along with my colleagues, Lori Hintz, Stephanie Meduna, and Carrie McDermott, we welcome and thank you for joining us today. Today's webinar is being recorded. It will be posted in a couple of days, business days, on our website at greatplainsquinn.org under the Friday Focus for Health tab. If you have questions while we're doing this presentation, please don't hesitate to add them to chat. There's a resource handout that Carrie's going to place in chat. You can access today's links to the tools that we have, and as well as the last 2 weeks. This is session 3 in our 4-week series. So we have learned a lot of different things over the last couple of weeks about avoiding emergency department visits and hospitalization. And this week we're going to talk about managing the person's condition, the possibly inadequate communication between nurses, caregivers, families, and physicians, and then what we might do when families are insistent on sending to the emergency department, as well as the need for those advanced care planning conversations. Next week, we will have our final Focus for Health of the series, and we will be reviewing infection and how they can lead to sepsis. We'll also discuss fall management and medication adverse events and how managing these things can help prevent avoidable ED visits and those rehospitalizations. So we will also talk about when you have success, to be sure to celebrate with your team, and that those small incremental changes are important and drive improvement. Here is the QR code. We love to hear from you. Are we doing a good job? How can we do better? And any ideas for future Friday Focus for Health that you can think of. So we'll have the QR code at the end of this while we have open office hours. So you'll have another opportunity. And there's also a link that you can go to do the evaluation. So to begin this discussion, there are a couple of areas that can really help reduce ED visits and hospitalization, but what you need to think about is all the multiple signs and symptoms of a patient or a resident, and maybe they don't have a clinical diagnosis, and then the lack of resources that you might have to manage the condition. Recently, I think McKnight's had a article that talked about once a person is placed in long-term care, there had been a significant reduction in the specialty care visits. That is one area you might want to look at. And then in the community, that person that has reduced visits from their primary care physicians, just due to the sheer volume they might be seeing of the specialty provider. So no one to really coordinate all that care. Also, the inadequate communication between healthcare providers, their families, the families of the resident or patient, and those specialty physicians can be an issue. So what can we do to help with this? We can educate nursing staff in correct assessments, evaluations, documentation, and communication of those clinical signs and symptoms. We like to highlight the utilization of the Interact SBAR tools. The SBAR is situation, background, assessment, and recommendation. And it can really help organize and take any emotion out in those calls to the doctors. If any information, just really organizing it. We are going to just watch a short SBAR video from the American Hospital Association.
SBAR can be a useful tool for quick communication, especially in an emergency. Let's look at an example where Lauren has noticed a patient having difficulty breathing and decides to take action.
Hi, John. This is Lauren calling from the Family Medicine Clinic. I think we need to transfer Mr. Smith to the ER.
What's going on?
The situation is that Mr. Smith is short of breath and is using accessory muscles to breathe. The background is that he has been working in a confined space the last few days with aerosolized chemical irritants. My assessment is his O2 sats are 88 and respiratory rate is 36. I think he's having some sort of reaction, and I would recommend you come see him now so we can get him transferred to the ER.
Got it. I'll be right there.
Think about what Lauren did well in this scenario. 1. She directed her message to a specific person, John. 2. She used the words from each letter in SBAR to make it easy for John to follow along. 3. She finished with a clear recommendation to help determine next steps for the patient's care. Overall, Lauren did a great job using SBAR effectively, giving John a clear understanding for how to move forward.
Another way is you can also use telehealth to improve offsite resident assessment by care providers. Use an admission nurse or an APRN who can assist in making choices on new admissions and hospital transfers. Provide evidence-based order sets that address the most common signs and symptoms associated with high transfers, diagnoses such as urinary tract infections, pneumonia, heart failure, COPD, and sepsis. Help offsite clinicians make informed transfer choices about the places they choose or want to transfer to. And then there's huddles. Huddles for the organization are effective when they use systems to foster timely, accurate, problem-solving communication that provides shared knowledge and goals. Huddles are just those short meetings, they're usually 10 minutes or less, that provide that needed communication piece. They are a good way to help improve communication because it reinforces teamwork and allows everyone to hear about the resident or patient so that all can provide assistance. You can complete huddles at the start of shifts, at the end of shifts to share information about the patient or resident. Quality improvement huddles focus on person or topics to analyze what's happening and why and what can be done about it. New patient resident huddles, you can have these as a way to let staff know about new people before they arrive and check in on how they're doing. Stand-up huddles that include leaders and management are good to share information that's needed by everyone in the organization. You can improve shift huddles to address issues early. Do you do walking huddles during some shift changes that include the resident or the patient? This can help with communication, not only between those caring for the person, but also to the family and the patient or resident. So we're going to take just a minute and watch a huddle video. And it is also from the American Hospital Association.
Back at the clinic, the team is getting a little behind on appointments, and one of them has to leave early. Skylar is a junior member of the team, but when he notices the lag, he decides to take action by calling for a huddle.
Hey, can we have a quick huddle over here? Just as a reminder, since it's almost 11, keep in mind that Vera has to leave at 11:45 today. It looks like we're getting a little behind schedule. Does anyone need help catching up?
Yeah, I could use some help with triage and med reconciliations before I have to leave.
Tell me which patient you're behind on, and I'll help.
Perfect. Thanks, Frank. Are we all good? Great. Let's do this.
Skylar felt empowered to call for a huddle when he saw things weren't going according to plan. By calling a huddle, the team was able to have a shared mental model of the schedule and plan ahead for Vera leaving early, which prevented their lag from getting worse. A huddle can be an ad hoc meeting to quickly react to unexpected change or to reinforce plans that are already in place. Either way, it doesn't need to take up much time. A huddle isn't a meeting just for the sake of having a meeting. It's a problem-solving tool that can help you and your team move forward with a renewed understanding and a shared mental model.
So these two videos are created and are from Team Steps. I don't know if you've ever heard of Team Steps, but Team Steps is an evidence-based set of teamwork tools that are aimed at optimizing outcomes by improving communication and teamwork and all the skills among the healthcare staff. You can learn more about team steps for different healthcare organizations from our Reducing Avoidable ED Visits and Hospitalization section. And I do just want to open this because all of the things in these 4 weeks that we're talking about are coming from our GP Quinn Reducing Avoidable Emergency Department Visits and Hospitalization Toolkit. And I want to take a second just to remind you of the small changes. What you do after you've analyzed your data and you know maybe what your issues are. You've done that root cause analysis. It's not doing everything that's in this toolkit, but looking at what your challenges are. Is it communication that you think is your top issue for the avoidable ED visits? Then use something out of our strategies for that section and then study it. And if it works, then you can spread it. When working with patients or residents and their families, be sure to determine preferences and answer questions about the hospital transfers. You can use the decision guide, go to the hospital or stay here when working with families. Family insistence to transfer their loved one to the hospital emergency department can be very common. This could come from a feeling of mistrust of the organization caring for the person. Many times, families have made the decision to move their loved one into a long-term care, and they sometimes carry that anxiety and guilt or feeling like they've abandoned their loved one. And those feelings can lead to some mistrust. So to combat that, ensure communication and confidence that your organization is able to care for the issues if able. While you're monitoring the patient or resident condition, keep the lines of communication open and share frequent updates to the family and other people in there. Creating a family communication plan, transparent communication, it keeps the families informed. It boosts confidence and trust in your organization and can improve satisfaction and engagement. Set communication expectations, uncover communication preferences, and determine what is to be communicated and develop a communication schedule. Another issue could be inadequate or missed opportunities for advanced care planning. This is a really important decision-making tool, and it is also important in age-friendly care that we've discussed in past Friday Focus for Health. It's that what matters, medication, mentation, mobility, 4 M's. And advanced care planning is about doing what you can do to ensure that the health care treatment received is consistent with a person's wishes and preferences. Advanced care planning should be discussed at every healthcare visit with all providers. This enables the healthcare provider to conduct structured, meaningful conversations with their residents or patients about their wishes regarding treatment goals, preferences, and location of care. It promotes patient-centered care by focusing on the personal preferences about their medical care and treatments. It helps ensure that patients and residents receive the care that's consistent with their own preferences and raises the likelihood that the healthcare provider and the family understands and complies with the person's preferences for medical care when the person lacks the decision-making capacity. It increases the probability that a person with life-limiting illness can die in their preferred place, such as home. It reduces decisional burden of families as to whether they are making decisions that are consistent with the preference of their loved one. It positively impacts quality of life and end-of-life care by preventing those unwanted ED visits and hospitalization, and increases the utilization of palliative care and hospice care services. It diminishes the use of aggressive or intensive treatments at the end of life and improves outcomes and person experience. So you might have watched this video, but it is it's an older video, but it's a really good video. Diane Sawyer did. It's on play it.
And finally tonight, ABC News wants to join you in something right at the heart of the American family. How we can all help the people who care about us make decisions near the end of our lives. And 9 out of 10 of you have told us that we should all be talking about it at all ages, what we want. And yet only a fraction of us have done it. And we know it makes a huge difference in the health of the caregiver as well as those cared for. So ABC News has taken cameras inside a vital, loving family, part of a new community, deciding to have the conversation. This is 85-year-old Norb and his daughter Maureen.
My dad is 85 today. He's still very, very active. He's a wonderful friend.
Throughout life, daughter and father have always talked about everything, except one thing: how to control the end of your life in the same way you control the prime of your life. So dad and daughter gather the family together, 3 generations, for an act of love.
And so now we're just asking that you share some of your thoughts about what you would like at the end of your life, so that we can honor your wishes.
They are part of something new underway for families in America that says having the conversation is a gift parents and children give each other. And there's proof of the difference it makes. Studies show depression rates plummet after a loss if the families have had the conversation. Renowned physician Dr. Atul Gawande says doctors and nurses see it firsthand.
When you're there in that moment and you're talking to the family and you're saying, how much will it bother your father if he ends up this way? And they say, more often than not, I don't know. We never talked about it. That it is incredibly traumatic for the family, for the doctors involved. There's often conflict. It can tear families apart.
So Dr. Gawande has become part of a team led by Pulitzer Prize-winning writer Ellen Goodman. It is called the Conversation Project. It is a kind of guide for families looking for a way to begin.
If we give them a way to talk about it and give people something to hang on to when they're afraid to start this conversation, they can do it and pass it on.
Families like the Jennings. They looked over the conversation guide before they sat down together. First, there's laughter.
Oh, my golf swing's still good.
And then Dad directly eases his daughter's guilt and worry about having put their mother in hospice.
I felt like that meant we were giving up on Mom.
She was in a lot of pain, and I think it was handled real well.
And next, Maureen asks her dad for clarity on what he considers a good end to a great life.
So if you were in a condition where you couldn't make decisions for yourself, how extreme would you want us to take measures to save your life versus letting you go?
Well, I think I'm ready to go anytime. You know, I wouldn't prolong anything. I mean, I've lived a great life. Pretty lucky. And because of you guys, you know. And
unexpectedly, a grandson is inspired to speak up about his own wishes for his own life.
That if there was no meaningful communication, that I would want you to stop trying to intervene.
We aren't ready for you to go that soon.
Well, we're not ready for you to go that soon either, so.
One by one, the others weigh in, all ages.
People don't do that.
Happy birthday, dear Grandma.
And with that, another family has joined a kind of estate planning for the heart.
Go!
The conversation beginning in America. So please tell us your stories in the days ahead about ways to begin the conversation.
Doesn't matter how many times I see that video, I get a little choked up. So now we are on to leave in action. By now, you might have pulled together your team, you might have analyzed your emergency department visits or your rehospitalization data, defined your problem after you've looked at your data, and now you want to work to improve it. Decide upon what intervention to implement, such as using one tool, the SBAR for communication if you're not or the change of condition cards, maybe the stop and watch tool. Those tools are that have are on the Interact website. Whatever your intervention is, study this, monitor the progress in small areas. Maybe it's one person, then you expand it to one unit or hall or wing, and then continue to spread it if it's working. That is the Plan, Do, Study, Act. Now we're going to move into our open office hours portion. This is a time for all of you to ask questions of your peers, as well as all of us here on the GP Quinn team. We are here to assist you in your quality improvement efforts. So we will open the space for you to think about what you might have as questions, any successes as you've been working on reducing emergency department visits or rehospitalizations, readmissions, or barriers that you've seen to reducing ED visits and hospitalization. And as you're gathering, you can use chat if you don't want to come off mute. Would love to hear if you've actually worked on it. If you're working on reducing your emergency department visits, while you're thinking about that, I do have a couple of polling questions. This one is, are you currently working to reduce avoidable emergency department visits? And Lori or Stephanie, because if you can let me know when you see people maybe slowing down on answering.
We're still having people respond, Tammy.
Okay.
Let's keep it open another 5 seconds or so because it's starting to slow.
Okay.
Oh. I don't know, Tammy, if you can see the results, but the vast majority have indicated yes, they are working to reduce avoidable ED visits. And we've had one person respond to no.
Okay. The next question that I'm going to launch is, do you currently use a hospital, a rehospital, or a readmission tracking tool, or a tracking tool for ED visits and readmissions? So I'm going to launch that.
The responses are still coming in slowly, Tammy.
Okay.
All right, it looks like they stopped. And if you can't see, I don't know, do you want to speak to it? If you can't see, 62% of our respondents currently do not use a tracking tool and 37% do.
Okay. Of that 32, 37, 32%, whatever that do use a tracking tool, would you just put into chat, is it a part of your EHR? Is it the Interact tracking tool that they have that we, I think, alluded to last week? What kind of, or something that you created yourself? Any respondents?
Nothing coming up now, Tammy.
Okay. If no respondents on that, did anybody have any peer-to-peer questions or something related to emergency department?
We just got a comment in, Tammy, and this comes from Jessica. She just started the Interact to track ED visits and was already doing hospitalizations per QAPI on Excel.
Good.
That's so great to hear.
Yeah. And Jessica, if you don't mind coming off mute and just talking about how that progressed, what you saw, did you have some data related to it? What made you take a look at that as a part of your QAPI and now the ED visits? Or you can type it.
Jessica, was this something that you had a high number of ED visits? Is that why you decided to go ahead and look at it, and rehospitalizations as well?
While Jessica is doing that, I do have one. It's a word. Oh, go ahead. I see she responded, but I can't read the whole thing. So.
Oh, can't use my mic, but we always tracked 30-day rehospitalizations, and then ED visits are now a focus as it was high. Perfect. Perfect. That sounds great.
You.
Thanks, Jessica.
Yes. So this is, and has a PIP. I see that one. I have a PIP ongoing. Okay. Well, good. If you do utilize a tracking tool, what has been the cause that you've seen for the avoidable ED, the highest? And we're going to just do a word cloud. So if you're using a tracking tool, has it been for urinary tract infections or skin issues, or family is demanding that trip to the ED? Whatever that is, if you would just, a word or two for what you've seen as the cause for those avoidable ED visits or readmissions. So somebody put fractures in, falls. Yeah. End of life.
Dehydration came up.
Infections. Yeah, so many different. But all of these, if you hang in with us next week, Lori's going to talk about infections and fractures or the falls, not fractures, hopefully no fractures. And just how to have some celebration with your staff. So we will go ahead, unless there's anything more in chat. Anything come up? Okay, we're gonna go ahead and end this, so you can go on if you are registered or you want to go to the blood pressure Friday Focus for Health. We'll give you that time to get on and logged on to that. So thank you guys, and please please give us an evaluation. Thank you.
Thank you.
Thanks.